Good morning, everybody. My name is Molly, and I will be teaching about severe trauma with increased ICP. I'm a nursing student at FTCC, and this is my presentation. Before we get started on what increasing intracranial pressure is, we need to go over what normal intracranial regulation is and what normal ICP looks like. Generally speaking, this is the process that controls intracranial compensation and adaptive neurofunctions. It's basically just what keeps things in homeostasis in the brain, and which that affects the entire body. And as you're going to see throughout the lecture, that there are multiple things that get affected once ICP changes or is manipulated in any fashion. The first thing we kind of are going to go over is what normal ICP is. It's different in different age groups because obviously there's different space in each age group because you grow and you get bigger and skulls get bigger and brains get bigger. So for infants, as you can see, it's 1.5 to 6. For children, it's 3 to 7. And then for adults, it's 5 to 15. And then the three items that make up the space around the brain, which is the brain itself, which is 85% of what takes up the space in the skull. And that's really important to understand that is primarily what is in our skull, is our brain. And so when anything else starts to take up more space, it is definitely going to push an effect on the brain, which then you'll see affects different areas of the body as it presses on different areas of the brain. 5% of the area is filled up with cerebral spinal fluid. That just keeps everything from sticking to one another and, not being able to move properly. And then blood, because the brain needs blood, which is 10% of the space that's in there. It's important for the brain to have blood because that is primarily how it functions. That's how it stays alive. To kind of what we're focusing on, which is increased intracranial pressure, and we'll bring in the trauma aspect of it, which a lot of times is what brings us to increased intracranial pressure. Usually this is defined with a sustained elevated pressure of 15, or ICP that is greater than 20 is an emergency situation. In adults, we can safely assume if that's an emergency situation for adults, that is in fact an emergency situation for kids. That is probably something that we will not actually see in kids. At that point, we probably already have death. Causes of increase in cranial pressure is hydrocephalus, and this is a genetic disorder, which is not what we're focusing on today. We're actually focusing on trauma, which will be closer to like stroke, head injury, tumors, or well, not necessarily tumors, but seizures. Tumors can kind of come from traumas, but primarily we're going to be looking at those. Primarily what I'm going to be kind of focusing on is a trauma based on like a car accident, a motor vehicle incident, because I think that is a great point of what we see with increased intracranial pressure is going to be a high collision, explosives even. As you'll see, we'll start talking a little bit about how military personnel are affected in this way with trauma and ICP. So it's also super important to identify and properly define what trauma is, because a lot of people just have a wrong idea of what trauma is, especially in our day and age when the word is used so frequently without a full understanding of what trauma is. Trauma, and I'll just read this off for you, results from an event or a series of events or a set of circumstances that is experienced by an individual as physically or emotional, harmful, or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. And this is quoted in the Pearson. You see my in-text citation, and the reference will be there at the end of the lecture. This is an important definition because a lot of times people will think of trauma, I think, primarily as a single incident. And so that is true, but it can also be a series of events or circumstances. Sometimes they don't even have to be strung together in it's like series of events is like, okay, this happened and this happened and this happened. Or a series of circumstances, a continuous circumstances, and we see that kind of in our examples with abuse. Abuse usually isn't a one-time incident. A lot of times it is this has occurred today, it occurs tomorrow, it occurs next week, it occurs next month, it occurs next year. And so that is also trauma. Now, each trauma is experienced differently, and it can, like it said, physical, social, emotional, spiritual, mental well-being is affected. What we're primarily looking at with trauma, though, is going to be a more physical. That does not mean that the other things are not caught up in that, because if you're going to feel something physical in a traumatic experience, there's definitely going to be all those other aspects touched as well. So the examples that we have for trauma are car accidents. Like I said, we're going to be focusing on motor vehicles today. And then there's natural disasters, mass casualties, and abuse. These are the different events that kind of hit all of those points. And there are tons more different not versions of trauma, but different classifications as well. There's more than just these when it comes to trauma. Risk factors for trauma and ICP, and again, this is going to be focusing on a more physical trauma, is going to be ignoring safety precautions. This is kind of like not putting on a helmet when you're going out and like on your bike, or if you're going to be skateboarding, stuff like that, not wearing a seatbelt in a vehicle, or even just following basic caution signs. I think that you can also see that with, like, if you are driving in the mountains and it says to slow down your speed when you're going up the hill with these switchbacks and stuff like that, and you don't do that and you end up in an accident, especially in the mountains, that can definitely cause trauma, and then in turn increase intracranial pressure. Alcohol use can definitely be a risk for trauma and ICP issues. Same with drug, and then some medication use, because a lot of times we do see that where we start a medication that was prescribed to us and that we're using for a certain reason, but then again, we don't know how our body's going to respond to that new medication, and then we do find out, oh no, I do actually have a bad response to this, an adverse reaction. There are people in our population who are at higher risk for trauma and ICP. That being primarily that we're going to see officers, that being military or police. For obvious reasons, our military go into war zones, we get blown up, they get into accidents. They do see a lot of trauma. And then, of course, our police. They're out here defending on the front lines every day, and we're going to see increased trauma incidents and ICP with them. And then healthcare workers, which is, at first you would not primarily think, oh, that's going to be someone who has trauma and ICP. But the truth of the matter is that that's something that we're going to face on a regular basis, especially if you're in those more high critical areas, thinking of ED or ICU. You can even think of psych wards, even nursing homes with people who have degenerating stuff, and we have to deal with family members on their worst days. This just causes a lot of issues here and there as things go along. You just don't know how people are going to react to the information that they are receiving. And then, of course, beginner drivers, because that does put them at more risk for trauma, for accidents, and just overall driver safety is lower than it is in adults who have been driving for a while, and so that's definitely going to put them at a higher risk. Our signs and symptoms of trauma with ICP, and a lot of times you're going to see a crossover here with trauma and ICP just because one causes the other. So for trauma, we're looking at swelling, confusion, loss of consciousness, high or low BP, just kind of depends on how the trauma is being experienced. The heart rate can be high, respirations will be high for obvious reasons. If you're in trauma, your heart rate's going to be high because, especially if your BP is low, to be getting that oxygenation around and getting help to the body parts that will need it. Respirations will be high for obvious reasons. You need more oxygenation to do that as well. Especially if we have bleeding, we're going to see those vital signs change. And then elevated temp is definitely possible, especially if there's an infection involved with the trauma, depending on what it is that we are facing. And then for ICP, decreased LOC, sluggish pupils, motor impairment, confusion, headache, vomiting, Cushing's triad, and temperature can be elevated, not always. Decreased level of consciousness is something that we are definitely going to be paying attention to. That is going to be one of your first signs increased intracranial pressure because it's pushing pressure onto the brain, and so that is definitely going to be one of the first things that you see. Confusion is definitely going to be one of the first things, and headache, because again, it's pressure. You're going to be feeling pressure in your head. Cushing's triad is where you have a widened pulse pressure, you have bradycardia, and irregular respirations, and this is usually just indicative of ICP. Complications of ICP and trauma, especially in a motor vehicle incident. I definitely believe that this is especially here. If it's not treated, it can result in a life-threatening complications, that being coma, stroke, seizure, brain injury, and death. Death might seem like an obvious thing to put on the list, but I think it gets overlooked, especially when we're talking about this. Mainly just because we just assume, if you don't treat something, it is going to end up in that. But this is an emergency situation. This is one of those things where it's like, if you don't respond in a certain amount of time, death is definitely going to be the outcome that you receive. And that's why it's super important for nurses and other medical personnel to be able to recognize the signs and symptoms of ICP, because if we don't, the longer we wait, the longer it takes to treat, and then more of these complications are possible to present themselves. The main tests that we're going to be looking at for ICP and trauma are going to be our CT and MRI. That is going to be the only way that we can see a change in fluid around the brain, and rather the brain has also changed. And so that's primarily what we're going to do when you start seeing those signs and symptoms, to actually fully diagnose that. And then EEG and TCD, and the Glasgow Coma Scale, that's just going to be mainly focused on our LOC and just our response. How bad is the increase in cranial pressure? And then supportive tests, because if you're in a trauma, let's be honest, you might need a blood transfusion, so we need to know your blood type so that we can give you the proper blood infusion. CBCs, just because we want to know all those levels, that's going to be important. And then cultures, because of course, if you've been in an accident, we might want to know if you've got anything in your system now. It depends on how long you've been out in that situation. It's just going to be good to know those things. So now we're going to look at treatment, and this is where we start to come in as nurses on getting these things done with the provider. Obviously, we're going to need to use collaboration here, and so we're also going to be doing our primary thing to lower ICP is surgery. There really is not another way to do that in a effective way that surgery does. Because we are going to be worried about breathing, respirations, we are going to do mechanical ventilation more than not. And then, of course, obviously treating the underlying cause, especially with trauma. If there's skull has been bashed in, something like that, depending on, crush syndrome, these different things, we're definitely going to be treating that underlying cause, which will also help lower the ICP. ICP monitoring, this is usually like putting a probe or something in the brain so that we're in that space, so that we can monitor the different fluids and levels in the brain, so that we can see that it is in fact lowering or maybe even getting worse. Our pharmacology is going to be diuretics like furosemide. This is just going to help lower fluids, and then antipyretics like Tylenol, because if you have a fever, that is probably going to raise your ICP. Anti-seizure medications, because whenever you're doing anything involving central nervous system, peripheral nervous system, brain, in these areas, it increases the risk of seizures, and so we want to make sure that we're watching that as well, especially because if our patient does have a seizure, this can increase intracranial pressure, and that's something we definitely want to prevent. And then if the MAP is high, we're going to do beta blockers. And then if the MAP is low, we're going to do vasopressors. And of course, IV fluids, because that's something that we definitely want to keep an eye on. Even though we do have increased intracranial pressure sometimes, that doesn't mean that we don't have insufficient fluid throughout the rest of our body. And so we definitely want to keep that in check. And so this is primarily where the nurses are going to be involved in nursing diagnosis considerations, because obviously we don't diagnose the patient with increased intracranial pressure. What we're going to recognize is percerebral tissue perfusion, risk for poor breathing pattern, ischemia, and brain death. And then the things that we want to do in order to maintain or fix or intervene in this area is to keep the head about 30 degrees. That's going to be super important, especially keeping just their bodies in a certain location, because bending is going to be a problem, and like changing of your body position can definitely increase your intracranial pressure. And so we just want to make sure that we're paying attention to body position. And then airway patency, because that's just following our ABCs, and that is going to be our A. And if you're not breathing, then the rest of it doesn't matter. And so we need to make sure that they have a patent airway. That's going to be like suctioning on a regular basis, doing oral care, taking care of the trach. That is going to primarily fall on us. We also want to prevent infection, because if you get an infection, that is inflammation. Inflammation increases in the brain. It could increase anywhere else, and that's just going to also cause ICP to rise. And then monitor fluids. That's going to be a huge part of this as well, because we want to get the fluid out and away from the brain, but we really want to make sure that we're not dehydrated or having any other issues there. And another thing that I put on here was patient education. That's one of the things that we kind of want to look at, especially once they're ready to be discharged, is telling them, like, okay, coughing, sneezing, bending over, lifting things, quick change in position. This changes ICP. And these are regular changes to ICP, which we expect, but the brain is usually able to compensate for those. But when they have a malfunction with their ability to monitor for ICP with inside their own body, we want to tell them different ways that they can keep that in check and make sure that they're not increasing their intracranial pressure on a regular basis, and then just making sure that they monitor those. This comes to the end of our slides. So this is just my reference page. Here you can see I do have two for Pearson, mainly because I just used the two different volumes, just because there was a lot of information in both of those. And then I do have ATI that I used, and then of course an article that I found online from the Lancet, which was also helpful with just the monitoring and information from that. If y'all have any questions, please feel free to ask. Thank you so much. Y'all have a great day.